This video will look at puberty blockers as a treatment for adolescents suffering from gender dysphoria. We'll go back to the origins of this treatment, back to the Netherlands in the 1990s. But first, a brief background on my interest on this particular topic. So my research started when I was trying to find evidence on the benefits of puberty blockers. And I discovered that the Gender Identity Development Service started an experimental study in 2011. The GIDS treats all children under 18 from England, Wales, and Northern Ireland. So I emailed them in 2018 asking for the results of the study, and there was no reply. So the fact that all trace of the study had disappeared really roused my interest and my suspicions. And so I started digging around, and to cut a long story short, my investigations led first to a blog post on the website Transgender Trend and to a book chapter. And this was taken up by the media, by the Daily Telegraph and by BBC Newsnight. And the research was used as evidence by Kira Bell and Mrs. A in their judicial review against the Tavistock and Portman NHS Trust. So now let's clarify what's meant by puberty blockers. So puberty blockers are a class of drugs known as gonadotropin-releasing hormone agonist, abbreviated to GnRHA. And they're also sometimes called LHRH, but it's the same thing. They block the production of sex hormones. They block the production of estrogen in females and testosterone in males. In the UK and the Netherlands, the drug is triptorelin. In America, the drug is a slightly different formula, and it's marketed as Lupron, but it has exactly the same effect. Now, these drugs have never been licensed to treat gender dysphoria. They've never been licensed for this condition anywhere in the world. What the conditions they are licensed for is, first of all, precocious puberty in children, where puberty starts abnormally young, let's say under 7 years old for girls. And this is the condition that is used by gender clinicians to justify treating gender dysphoria, even though the two have really nothing in common. Because the drugs stop sex hormones, they're also used to treat some reproductive problems in women, though it's interesting that women can only allowed to take them for up to 6 months, because they have such serious consequences. And they're also used to treat prostate cancer in men. And in fact, GnRHA was first developed to treat prostate cancer. So one of the licensed use should be mentioned, and that is the treatment of what is called severe sexual deviation in men. Put it plainly, they're used to chemically castrate sex offenders. A recent review actually warned that they should be used only for the worst sex offenders because they have, to quote, extensive side effects. So to an outside observer, it does seem a bit odd to give the same drugs to children suffering from gender dysphoria as are used to chemically castrate sex offenders. Where did this idea come from? So here's the article that introduced puberty suppression to the medical community. The title is "The Feasibility of Endocrine Interventions in Juvenile Transsexuals." Note the phrase, juvenile transsexuals. The first author is Louis Geuren. Forgive me mangling his Dutch surname. He was the world's first professor of transsexology, and he was based for many years at the Free University of Amsterdam. The second article, which is the one that's more often cited, is Pubertal Delay as an Aid in Diagnosis and Treatment of a Transsexual Adolescent from 1998. Transsexual adolescent is also a phrase to keep in mind. The first author of this article is Peggy Cohen-Kettenis, who was then based at the University of Utrecht, and then she subsequently moved to the same university in Amsterdam. This article described the very first case of puberty suppression. This is a girl known as B, who was a tomboy. She played with boys' toys. There was conflict with her father, quite a lot of problems in the family, and at 12, she even threatened suicide. At the age of 13, her psychiatrist and a pediatric endocrinologist decided, therefore, to delay B's puberty by triptorelin treatment. Using this hormone, she started to feel better about herself, thus allowing her therapist to explore gender issues for an extended period. The exploration lasted until 18, and then she very quickly went through the transsexual process. Testosterone, double mastectomy, removal of her uterus and ovaries, legal sex change, and finally, genital surgery. According to Cohen-Kettenis and her co-authors, this apparently completely cured her. B reported no gender dysphoria at all. And that's after a year. B never felt any regrets. B is happy and studying to be a doctor. So we can see why this article had such an impact on clinicians working with kids with gender dysphoria. Puberty suppression almost seems to be a miracle cure, which could enable a perfect sex change, if only you could start early enough. We'll come back to the case of B later on in the video, but meanwhile, as an exercise for the viewer, why don't you take a guess at B's sexual orientation? Do you think she's erotically attracted to women or to men or both? So we could begin by trying to understand what motivated these clinicians, the father and the mother of puberty blockers. Well, Heron believed that some people are born with the brain of the opposite sex. So he stood in the long tradition, started with John Money, who invented the notion of gender in the 1950s, the notion that transsexualism was kind of like an intersex condition, what we'd now call a disorder of sexual development. So the argument goes that you can't change someone's brain, so you have to change their body to match their brain. That's the only solution. For Cohen-Kettenis, the motivation was a bit more practical. She ran a gender clinic for young people in Utrecht, and she'd begun to lower the age for cross-sex hormones from 18 down to 16. And her findings, she argued, she argued was that it was much better to start younger. Transsexuals who started earlier were more likely to pass, and as a result, they were much happier, much better, more well-adjusted. So, of course, logically, the next step was to lower the age further. Hence, what became the Dutch protocol. So, under this protocol, at the age of 12, a child will become eligible for puberty blockers. At 16, the child would go into cross-sex hormones. And at 18, they would go for their surgeries. And in the Netherlands, genital surgery was standard. So there's a very straightforward conveyor belt. Puberty blockers, hormones, surgery. Now, Dutch clinicians were aware, because they were starting young, they did say that they imposed quite strict eligibility criteria for puberty blockers. First, the gender dysphoria should have begun early in childhood. How they would actually know that is unclear. Presumably, they'd have to rely on the patient's own recollection and the family's recollection. Also, the dysphoria should have become worse with the onset of puberty. Second, the patient should be psychologically stable and not suffer from other mental health problems. And third, the patient needed to have the support and approval of their family. So these eligibility criteria were usually forgotten when the Dutch protocol was adopted in other countries. What was taken was simply the idea of puberty blockers at 12. And in other countries, the age of 12 was soon reduced because, after all, some children start puberty earlier, and so you need to go younger than 12. In England, for example, the youngest so far is 10 years old. One more thing about the Dutch protocol is that Ferring Pharmaceuticals was remarkably generous with financial support, and that, of course, is the company that manufactures triptorelin. So let's look a little more closely at the Dutch protocol. So the first thing is the connection between gender dysphoria and homosexuality. In Geuren's first article on puberty blockers, there's an intriguing statement. Not all children with gender atypicality will turn out to be transsexuals later in life. Several prospective studies in gender atypical boys show that this childhood behavior correlates considerably stronger with future homosexuality than with transsexualism. So doesn't that raise the prospect that most of Geuren's juvenile transsexuals are really homosexuals to be, or homosexuals in waiting? The passage continues with something that seems to be a non sequitur. Some of the youngsters will turn out to be genuinely transsexual in their mid-teens. But that's some, not all. And starting at 12 means starting, of course, before the mid-teens. Yet the claim is that there is no reasonable expectation that their cross-sex gender identity will ever more change. Here they cite articles by Cohen-Kettenis, which actually don't provide any evidence that cross-sex gender identity never changes. It just simply describes how she is operating her clinic in Utrecht. So a later review article by Cohen-Kettenis and Geuren repeat the same point. Not all children with gender identity disorder, and that's just the earlier term for what we now call gender dysphoria. Not all children with gender dysphoria will turn out to be transsexuals after puberty. Prospective studies of gender dysphoric boys show that this phenomenon is more closely related to later homosexuality. Again, the same kind of puzzle. And this puzzle has never, as far as I tell, been tackled. Let me illustrate what exactly is the problem here. And I'm using here on an excellent recent article by Lee, Kung, and Hines, which uses data from a large cohort study of kids born in Bristol in England. Lee very kindly shared the data from the article so I could make my own graphs, and the details of the study and my graphs, my analysis is posted on the website Fourth Wave now. So when these kids were almost 5 years old, their parents were asked about what sort of toys they liked and who they played with. Their answers were used to create an index of gendered activities, and so from masculine to feminine. And of course, naturally, by definition, there's a real clear difference between boys and girls on average. But some boys actually resemble girls more than or the typical girl more than they resembled the typical boy. They're on the left-hand side of that, the histogram in red at the bottom. Obviously just a few percent, but nevertheless, there are quite a few of them. Now guess what, when the same kids were followed up 10 years later? Age 15, the children were asked about their sexual orientation. As you can see, the boys who had preferred, as small children, more feminine activities were far, far, far more likely to identify as gay. Although note that still, it was only a small minority. At the maximum, you would predict only 20%. Oh, of course, we would expect some of them would come out as gay later. 15 is still young. And exactly the same pattern holds for girls, although it's not quite as pronounced as it is for boys. Now, it's important to note that one of the criteria used to diagnose gender dysphoria in children is engaging, and I'm quoting, engaging in play activities characteristic of the opposite sex. Remember how the case of B emphasized how that she had played with boys' toys. So it would be nice to know how practitioners of gender medicine distinguish a transsexual from a homosexual. One path requires lifelong medical treatment, the other does not. Now let's take the claim for reversibility. This is one of the key claims justifying the Dutch protocol. In Geuren's initial article, the effects of puberty blockers are fully reversible. In other words, no lasting undesired effects are to be expected. Side effects are few, particularly when there is usage only for a limited period of 3 to 18 months. So presumably Geuren was thinking about using puberty blockers for a limited time, but of course B used them for 5 years, from ages 13 to 18. And when adopted elsewhere, kids can start, outside the Netherlands, kids can start as young as 10, so that's 6 years to 16, 10 to 16 when they can take cross-sex hormones. An article 10 years later repeats the same mantra of reversibility. But a hint of doubt appears later in the same article. During puberty, developmental processes also take place in the brain. It is not clear yet how pubertal suppression will influence brain development. So one might think that the effects of puberty on brain development and the suppression of puberty on brain development would have warranted investigation at the outset, but it certainly calls this claim about reversibility into serious question. Another mantra in the Dutch protocol is diagnostic. This treatment is a very helpful diagnostic aid, as it allows the psychologist and the patient to discuss problems that possibly underlie the cross-gender identity or clarify potential gender confusion. Hypothetically then, puberty blockers enable you to diagnose who is truly a juvenile transsexual and who is gender dysphoric but not transsexual, for example, just a gender non-conforming gay or lesbian, or for that matter, bisexual or heterosexual. But the same article later admits none of the patients who were selected for pubertal suppression has decided to stop taking GnRHA. Since then, we know that almost everyone who takes puberty blockers goes on to cross-sex hormones. The figures, and this is not just the Netherlands, but in other countries as well, like Britain, the figures are kind of always something like 97%, 98%, or 99%. So this is a very strange, a very peculiar diagnostic test, for it almost always yields the same result. One last point to be made about the Dutch protocol. The aim is to block the development of sexual characteristics to avoid subsequent interventions to get rid of those characteristics. For example, a boy won't develop an Adam's apple, and so he won't need a tracheal shave surgery. He won't develop facial hair, so he won't need electrolysis. However, there is one major downside for males. It was acknowledged, as far as I can tell, only in 2008. Genital surgery for males uses the penis to form the inside of the newly created orifice, or neovagina. But puberty suppression means that the penis is likely to be too small, because after all, you have a man with the body, with the penis of a pubescent boy. As Cohen-Kettenis and colleagues write reassuringly, the genital tissue available for vaginoplasty may be less than optimal. However, appropriate adjusted techniques exist to deal with the shortage of tissue. This is using a portion of the patient's bowel to line the new orifice. But this is a much less common and more difficult surgery to create a vaginoplasty. So suppressing puberty has one significant disadvantage for a male transsexual, which needs to be balanced against the potential advantages. So let's finally return to B, the very first adolescent given puberty blockers. B was followed up after 22 years since GnRHA was prescribed. At that point, B was aged 35 years old. When you read the abstract of the article, this looks like a clear success. B was in good health. B had bone density within the normal range. And this is one thing I didn't discuss, that puberty blockers prevent bones growing as they should, though this seems to be recovered when cross-sex hormones are taken. There's some concern about B's height because appearance is really important for these clinicians, and not just the Dutch. It's quite widespread in gender medicine, a lot of concern about trans women being too tall and trans men being too short. But as the abstract concludes, negative side effects are limited. So it seems great. But then when we start reading the text, we learn that B is good looking. Again, this emphasis on appearance. But B's relationships really have not worked out so well. B broke up with his girlfriend due to shame about his genital appearance and his feelings of inadequacy in sexual matters. B was rather sad and indeed depressed, although didn't meet the threshold of clinical depression. So B's situation hardly seems a great advertisement for the Dutch protocol. It's true that B didn't regret the path taken, but then, of course, regret would be rather pointless once you've made such a series of irreversible decisions. What's remarkable is that Cohen-Kettenis and her co-authors can't envisage any counterfactual, any possibility of the 13-year-old girl dealing differently with her gender dysphoria and following another path. So let me conclude by repeating some questions that are raised by the Dutch experiment. As we've seen, the justification for puberty blockers is contradictory. On one hand, the drugs are supposedly a diagnostic tool for discovering whether someone is, or perhaps should be, a transsexual. On the other hand, the drugs are the first stage of sex change. This is clear in the titles of the original articles. Remember, juvenile transsexuals, transsexual adolescent. By the mid-2000s, if not before, it was clear that adolescents given puberty blockers will almost always progress to cross-sex hormones and surgery. Were the Dutch clinicians and subsequent clinicians in other countries incredibly skilled at identifying those juvenile transsexuals? Or did the process of labeling a child as a juvenile transsexual tend to lock in the child's identity? Or, for that matter, did the drugs, by suppressing sexuality and suppressing cognitive development, prevent alternative ways for the kids to make sense and to overcome or to cope with their dysphoria? That leads to the next question. How do we know whether some of these transsexuals could not have grown into homosexual or indeed bisexual adults without needing hormones and without needing surgeries? After all, as the Dutch themselves pointed out, most boys suffering from gender dysphoria used to grow into gay men and girls into lesbians, or at least they used to before the era of puberty blockers. Third question, why did the Dutch clinicians never carry out a randomized controlled trial? That's the normal procedure to use when you invent a new experimental treatment. A randomized controlled trial provides real evidence on the treatment's safety and effectiveness. And note that even in the current public health crisis of COVID-19, despite the urgent need for a vaccine, vaccines have still gone through this process of going through a randomized controlled trial to make sure that they're safe and effective. And the Dutch didn't even test their new treatment on animals. It would have been easy to demonstrate whether puberty blockers are reversible, as they claimed. Only recently have scientists at the University of Glasgow actually done this kind of experiment on sheep, and they find that puberty blockers cause cognitive defects in spatial memory, and those defects do not disappear when the puberty blockers are stopped. The Dutch, however, used children as their guinea pigs. The final question is about the balance between, on one hand, appearance and on the other hand, sexuality and fertility. It's very clear reading the Dutch publications that their priority is looking good. They want these juvenile transsexuals to pass as the other sex. And of course, that obviously reflects the desires of the patients themselves, who desperately want to transform their appearance. But in all this, what bodies can do seems almost forgotten. Potentially negative effects on sexual pleasure, on libido, and on capacity to orgasm, and potentially negative effects on reproductive capacity are neglected. And so one really wonders whether the clinicians have got the balance right between what bodies look like and what bodies can do. So I hope my brief history has proved informative. Slides with all the references are posted on my website, which is linked in the description. Read sources and make up your own mind. And I'll leave the last word now to the father of puberty suppression, Louis Geuren.
But we are very, very reserved about this treatment. I mean, hormonally speaking, it's safe, but psychologically speaking, did we do the right thing? Do people of 13 never have second thoughts of what they are doing?